Okay. Good morning, everybody, and welcome to our presentation today. We are really lucky today to have Dr. Lara Greenstein presenting to us. Dr. Greenstein obtained her undergraduate and postgraduate degrees from the University of the Witwatersrand. She runs the geriatrics service at Helen Joseph Hospital and founded Gauteng's first public hospital fracture liaison service. She is the Vice President of the South African Geriatrics Society, where she advocates for advancing geriatric teaching across the country. With a passion to enhancing care for older adults, Dr. Greenstein is dedicated to educational initiatives in local forums and across Africa. She is currently supervising a number of MEd projects in geriatrics and is pursuing the postgraduate diploma in health science education to further refine her educational skills. She's the academic head of the Division of Geriatric Medicine at the University of the Witwatersrand. Thank you so much for taking the time to come and present to us. We appreciate it.
Thank you so much for inviting me, and thank you for having me to talk about this really important condition. So today I'm going to be speaking about major neurocognitive disorder, which is basically dementia. It's not going to be a comprehensive review on the pathophysiology. It's just going to be more of a practical approach in what I do when I'm faced with a patient who's got a memory problem. So this is our practical approach to dementia. So when I look at a patient who's got dementia, I like to ask a few pertinent questions because I feel that by answering these, then you'll have a holistic view of the patient and know what to do going forward. So first we have to answer the question, is it actually a dementia? Then once we've determined that it is dementia, is there anything reversible that we can do to make the patient's life better and maybe to even reverse the actual symptoms and signs, which would be amazing. Then once you've decided that there aren't any reversible factors and it is actually a dementia, what cognitive tests do you do? And then you want to type the type of dementia that it is. So put a name to the clinical syndrome because that's what the patients and the family quite often want to know. Sometimes you can't. So if it's very late in the presentation, then it's not as important as if you catch the person earlier. Then you want to know if there's any treatment or prevention. And then you want to know where you can get some help. So where the caregivers can get some support and where the patient can get some support. So this is just an algorithm that I quite like to follow. So you get a patient who comes in who either complains about memory loss or their family member or caregiver complains that they've got memory loss. And now you have to ask yourself, is this dementia? So before you decide whether it's dementia or not, you have to rule out the two most important mimickers. So you have to make sure that it's not a delirium, which is, has a fluctuating course and it's more acute. And you have to rule out depression because depression can present as a pseudo-dementia. Then once you've decided that this is actually dementia and it's not one of those other two, you have to do some brief screening tests. You have to assess their functional ability. You have to do a history and exam. And then you have to decide if everything is normal, then you follow up and reassess periodically. And if it is abnormal, then you have to do further tests. You have to rule out all your reversible conditions. You might want to do some blood tests, some imaging, and then you want to name the syndrome to help the patient and their family. So this is just a really simple version of what we're going to be speaking about today. So just to remember that as people age, they do become a little bit more forgetful. As long as it doesn't impact on your day-to-day function, it's normal. So if you put your keys down and you forget where you've put them, and then an hour later you suddenly remember, I put them wherever you put them, that's normal. The minute it starts impacting on your function, so like you forget your how to pay your bills, or you forget to take your medicine, which is a safety risk, or you forget how to drive or where you're going, those things impact on function, and then it's not normal. And then there's a whole gambit of dementia from your asymptomatic preclinical presentation to your mild cognitive impairment all the way to actual dementia. And the time course varies depending on what type of dementia you have. But minor forgetfulness episodes is actually normal. So when we're looking at whether it is or isn't dementia, we look at the DSM-5 criteria, and we want to distinguish between a major neurocognitive disorder, which is the correct term for dementia, or a mild neurocognitive disorder. And how we do this, that if it's a major neurocognitive disorder, there has to be a significant cognitive decline from your previous level of performance in one or more of the cognitive domains. And there are many cognitive domains, and they include things like complex attention, executive function, learning, memory, language, perceptual, motor, or social cognition. And then it has to interfere with your independence in everyday activities. So it has to have some functional interference. Whereas with your mild neurocognitive disorder, there's a moderate cognitive decline. Normally, the patient has a subjective feeling of there not being something right, but it doesn't really impact on day-to-day activities and independence. And then these cognitive defects can't occur in the context of a delirium. So you have to rule out a delirium, and they can't be explained by some other mental disorder. So, for example, a very depressed patient or somebody who's psychotic. And then you can classify whether the dementia has behavioral disturbances or not. And then you can decide what type of dementia it is. So just to reiterate, it has to be a significant cognitive decline, and it has to interfere with your functional day-to-day activities. So if we look at the numbers, the number of people with dementia is going to increase incrementally. So from 57.4 million cases globally in 2019 to 152.8 million cases in 2050. But of course, the incidence increases as you get older. So in those who are 60 years old, only 1% of patients will have dementia. But as you get older, when you reach 85, up to 45% of patients will have dementia. So it's much more common as you get older. And then I just copied and pasted a small part of this table into the slide to show you that in South Africa, there's going to be a 181% increase in dementia from 2019 to 2050, which is huge. And there are also not a lot of geriatricians, neurologists, psychiatrists, people who are au fait with the condition. So it often lands up for the GP or for the specialist physician to deal with these problems. And, you know, no one's really adequately trained in dementia. So that's why it's important to know a little bit about it. So once we've decided that this is a dementia, then the next step is to decide, is there a reversible cause or not? And I love a good mnemonic, and this mnemonic is dementia. So if we're looking at whether there's something that we can improve, we're going to look at this mnemonic. D is for drugs. So certain medication have really adverse effects in older adults. And these are things like your benzodiazepine, sometimes your analgesics. There's a whole host of drugs. So you have to do a good medication review and decide if there's anything that's causing cognitive decline, and then you can stop those and see if there's an improvement or not. E stands for emotional, so you have to rule out depression, and it also stands for ears and eyes. So if you aren't plugged into your world, you can't interact with the world, and your cognition's not going to be normal. So you have to make sure that your older patient can see and hear properly. Then we look at M, which are your metabolic disturbances, most commonly hypoglycemia. So if the patient is diabetic and they're on a whole lot of anti-diabetic drugs, you know, maybe they're having hypoglycemic episodes that they're not aware of. And then thyroid disorders. So either hypo or hyperthyroidism can cause cognitive disturbances. E are your electrolyte abnormalities. And the most common ones here are sodium and calcium abnormalities. Then N is normal pressure hydrocephalus. So here you're going to do a CT scan and see if there's normal pressure hydrocephalus, which is one of the more satisfying dementias to treat because it can improve with a surgical procedure. And also nutrition. So here we're looking more at your vitamin B12 and folate deficiencies. T is tumor or any space-occupying lesion, and this even includes space-occupying lesions like a subdural hematoma. There's just no S in dementia, so we stick it under tumor. Then I is infection. So here we're looking at things like HIV and tertiary syphilis. And then A is alcohol. So those people with a strong alcohol history, and anoxia. So normally by the time you've got anoxia, you'll be deceased, but more hypoxia, but there's also no H in dementia. So the A just fits there. And then once you've decided that it is dementia and there's no reversible cause and you've ruled everything out, how are you going to actually decide that this person really does have dementia? Well, you're going to do some cognitive tests. And there are a whole gambit of cognitive tests. Some take a long time, some are really quick. So if we're going to screen for dementia, like you've got a patient in the ward, they're a little bit slow, you're not 100% sure whether they, just not hearing you very well, they're in a new environment, they're very, very stressed and anxious. You want to do just a screening test to see is their cognition okay or not, because you're not going to do full tests on every single patient. Then we do something called a mini cog, and we'll go into that in a bit more detail just now. Then, if you want to do a bit further testing, you'll do your mini mental state examination if the patient is only able to do their basic activities of daily living by themselves. And if they're able to do instrumental activities of daily living by themselves, so this is things like shopping, cooking, organizing their own transport, using a telephone, managing their own finances and medications, then you can do a MOCA. The mini mental is better for tracking progression over time, and you can also determine the dementia severity with the mini mental state exam. You are supposed to pay for it, $1 per time you use the test. And with the MOCA, there is training that's meant to be done. So it's really useful to just do the mini cog screening tool, as a baseline test. So this is the mini cog, and it's one of the most useful geriatric tests available. It takes 2 minutes. So you ask your patient to please remember 3 items. So it's something like a pen, an apple, a table, or a dog, a hat, a coin, whatever 3 items, which you also have to remember. And then you ask them to repeat it. So you're testing their immediate recall. So you're just making sure that their attention is actually okay. And then you're going to ask them to draw a clock. And you're going to ask them to put all the numbers in the clock and put the hands on either 10 past 11 or 10 past 9 or 1:45. And then you're going to ask them, what were those 3 items that I asked you to remember? If they're able to remember all of the 3 items, they pass the test. If they remember none of the 3 items, they fail the test. And then if they get 1 or 2 correct, you can look at their clock. If their clock is normal, they pass. And if their clock is abnormal, they fail. And then you'll go on and you'll do some other further testing. But I mean, it's quite nice. The clock shows a lot of planning and sequencing and executive function. And the common errors that we see is that there'll be a hand on the 10 and the 11 if you ask them to make the time 10 past 11 instead of the 11 and the 2. Or if they've had a stroke, maybe they'll only put all the numbers in half of the clock. So you can tell quite a lot by just the clock drawing test. And you can also tell if somebody's really unable to draw a clock at all, you're certainly not going to think that that person is safe to manage their own finances or to manage their own medications. So that's the mini cog, and it's really, really simple and very important. Then we've got your mini mental state exam, which I'm sure you all remember from university, where you sort of ask the patient a whole host of questions spanning from orientation to immediate recall, delayed recall, a little bit of attention, a little bit of memory, some executive function, a little bit of visuospatial stuff when they copying the pentagram. And then depending on the score, you can decide whether their dementia is mild, moderate, moderately severe, or severe. So if you score less than 10, you've got severe dementia. And at this point in time, you actually expect the patient to have difficulty with speaking, mobility, and swallowing. And at this point, you really, really do need full-time care. So like a frail care setting or full-time help at home. If the score is between 10 to 14, it's moderately severe dementia. And at this point, you expect a little bit of incontinence to start. And again, these people are going to need help with everything. Then if you're scoring 15 to 19, you've got moderate dementia. And here you're going to start to need help with some basic activities of daily living. So you might still be able to go to the toilet, but you might need help getting dressed, and putting your socks on before you put your shoes on and that sort of thing. And then if you score 20 to 24, that's mild dementia. And people who are in this category, usually just need help with instrumental activities of daily living. So they can do things like eat by themselves, go to the toilet, transfer from a bed to a chair, but they're not really able to organize their own transport, for example, or go shopping and pay the right amount of money and not forget their PIN number, that sort of thing. So you can track with the mini mental the disease progression and the rate of decline, which is quite useful. Obviously, again, it depends on the type of dementia you have, but it's very nice for long-term follow-up. If your patient, however, can do all their instrumental activities of daily living by themselves, and you've got a very high functioning patient, who's still working, who's still, the CEO of their company, and who's still running around and doing all their own things, the Montreal Cognitive Assessment is probably the better test to do. It has a lot less emphasis on things like orientation and has a lot more emphasis on your visuospatial and executive function and your attention and learning. It even tests things that the mini mental doesn't test, like abstraction, and their delayed and immediate recall is much longer. So it's 5 items instead of 4 items. Instead of 3 items. And here you can also test a little bit of language. So you can kind of start to tell what dementia the person might have by really interrogating the results of the test. Obviously, if you're not so au fait with the test, just getting a baseline number and seeing which domains the person falls short in is absolutely fine. This isn't as good as tracking disease progression over time as the mini mental is. And obviously, if your patient has a lower level of education, you're not going to do this test, and you might also have to modify the mini mental. And if somebody's had a stroke and they can't write, then obviously you can't give them 0 for their sentence. You might have to just score the test out of less and make allowances for that. So once we've done these screening tests and we've decided that our patient does have dementia, we have to actually understand what dementia is. And this is an umbrella term which has a range of symptoms associated with cognitive impairment. And under this dementia or major neurocognitive disorder umbrella, there are a whole lot of different types of dementia. So the most common is Alzheimer's. That's 50 to 70% of your patients. They'll have Alzheimer's disease, which is much more common in your older patients. Then the next most common is your vascular dementia. Then comes your Lewy body dementia or dementia with Parkinson's disease, which sort of fall under their own little umbrella. And then you get things like frontotemporal dementia, and then there other rarer variants of both of all of these. But these are the most common ones, and these are the ones that we see in everyday practice. If you catch the person with dementia early and you're going to start instituting some preventative and some care measures, it's really useful to know what type of dementia the person has. By the time the patient has severe dementia and the mini mental is less than 10, it often, it's difficult sometimes to tease out exactly what type of dementia it is. You need quite a lot of collateral history, and it's always easier if you know the person from before. So just to remind you that there's a significant decline from a previous level of performance in one or more cognitive domains, which makes you think that this is dementia, and it interferes with your day-to-day function. And once you've satisfied those criteria, then you can decide which dementia it actually is. So I really do love this diagram over here from this Grand et al. In the Journal of Multidisciplinary Healthcare in 2011. It's such a useful diagram, and I use it and I show it to all my registrars and my medical officers, because it basically is a summary of dementia in one slide. So again, here you're looking at your mild cognitive impairment, where your cognitive complaints don't really interfere with your activities of daily living. And then you decide that, if there's a reversible cause of dementia, you sort of rule that out. And then once you've decided it's not a mild cognitive impairment and there's not a reversible cause, then you can classify the dementia, which is also really helpful for the patient and their family, because a lot of people want to know, what dementia do I have? Oftentimes it's mixed. So you can tell them it's probably a mixture of, it's normally a bit of Alzheimer's and vascular, or whatever mixture you think it might be. It's not always cut and dry, but there are clues to help you decide what dementia is it. So some of the important clues for your Alzheimer's dementia, for example, it's a gradual onset of symptoms, and it's a progressive decline. And you can basically tell exactly how your patient's going to progress. Usually I think the average is about 10 years, 10 to 12 years. And you can kind of tell at first you're going to have memory loss, then you're going to have mobility issues. Then at the very end, you're going to have swallowing difficulties, and you're going to forget how to walk, and you're going to forget your family's names, etc. So that one's got quite a well-documented progression, and it's mostly short-term memory loss in the beginning, and the long-term memory is still quite intact. Then your next most common cause of dementia is your vascular dementia. So this is usually a more acute onset, and there's usually a precipitating factor. So the person has a small little vascular insult, and then you can see at that point there's some deviation to their normal, and then they carry on that sort of stepwise progression until the next insult happens, and then there's another deterioration, and you never go back to your previous baseline, but you sort of carry on at your new baseline until there's another insult. And with this dementia, there's normally neurological signs or something that you can see on neurological imaging. The patient usually has vascular risk factors, which doesn't always point towards vascular dementia, because the risk factors for Alzheimer's dementia are also the vascular risk factors. But there's usually, long-standing hypertension, you might hear a bruit, you might have some upgoing replanter or some brisk reflex. So there's something to point you towards a vascular cause. Then your rarer types of dementia, which do deserve a mention, are things like your dementia with Lewy bodies and your Parkinson's disease dementia. So this is much less common, but it is quite a devastating disease, and it does have management implications. So if you're thinking of a Lewy body or a Parkinson's disease dementia, you have your Parkinson's symptoms, and then it presents more like a long-term delirium. So you have hallucinations, and you have this fluctuating course of disease. And there's quite a lot of executive dysfunction and visuospatial problems. People often see very distinct visual hallucinations. So it's usually little people or little insects that are crawling on the bed, or small animals, that sort of thing. And the distinction between Lewy body and Parkinson's disease dementia is just the timing. So if you've had Parkinson's disease for at least a year, and then you start getting these dementia symptoms, it's probably Parkinson's disease dementia. But if the dementia symptoms precede the Parkinson's symptoms, or it happens within a year, it's more likely dementia with Lewy body. And this is important because they're very, very sensitive to your neurotropic drugs. So here you just want to be careful in what medications you give. And then the other dementia that deserves a mention is your frontotemporal dementia. So here we can think of Bruce Willis, who has primary progressive aphasia. So that's the one type of frontotemporal dementia where language goes. And how you know that it's more of a language frontotemporal dementia as compared to an Alzheimer's dementia, the level of function doesn't equate with the loss of language. So even though they can't speak at the beginnings and they're losing words, their function is still okay. They can do certain activities that they were doing before. And then you get your behavioural variant, where their personality changes and people eat everything, they drink a lot, they lose their empathy, and they just change their personality completely. So once we've decided that that you've got dementia and we've classified it, we can just look and see that there are two different entities, I suppose, your cortical and your subcortical dementia. So if we look at your cortical dementia, these are things like Alzheimer's, and your frontotemporal dementia, you don't really have as many clinical signs. It affects more the outer gray matter changes in the four lobes of the brain, depending on where the problem is. And you have a lot of memory loss, difficulty with mental processing, and you can have quite a few visuospatial problems and apraxia, basically. Then if you look at your subcortex, which is the gray-white matter interface and the connection between, this is usually your vascular dementia or your dementia with Lewy bodies. And here you often get clinical signs, very slow and rigid thinking, difficulty in planning and sequencing, and difficulty with mental manipulation. And often the difference between the subcortical dementias and the cortical dementias is that they're both forgetful, but with subcortical dementia, they can sometimes improve if you give them a clue. So if you've asked them to remember those three objects, the pen, the apple, the table, if the person with Alzheimer's dementia, you say to them, what were those objects? And they say, I don't know. You then ask them, the one was a fruit. And then they'll tell you, oh, it was a banana or something that you didn't say. Whereas a patient with a subcortical dementia will often say, oh, yes, it was an apple. They just need that clue. The memory is in there. It's just difficulty getting it out. Whereas with your cortical dementias, often the difficulty is storing the memory in the first place. Right. So just to reiterate, there's no panacea. There's no cure for dementia. So you can't diagnose somebody with dementia and then say to them, oh, you're better. So we have to prevent dementia. And this starts in early age and midlife. So I'm one of those people who now have to start preventing my future dementia because I feel that at 40, I've hit midlife. So in early life, you have to reach your educational potential. In midlife, you have to make sure that you can hear properly, that you control all your risk factors like cholesterol, diabetes, hypertension, go on a diet. So the Mediterranean diet is the best because you don't want to be obese. You want to limit your alcohol intake. You want to stop smoking. You want to get adequate physical activity. If you're depressed, you need to treat the depression. Try and avoid traumatic brain injuries. And then later in life, you want to prevent social isolation because that causes depression and you unplug from the world around you. You want to try and prevent air pollution, which in some cases is absolutely impossible. Maybe they're advocating to go and live in one of those lovely little seaside towns where everybody's friendly and there's a good community spirit, nice and clean. And then you want to make sure that there's no visual loss. And if you can control all of these risk factors and start working on them from midlife when it's really important and take care of all of these contributing factors, you can prevent up to 45% of dementia, or you can at least modify it so that you get your dementia at a much later age. Obviously, this doesn't take into account things like genetics. So if you've got an ApoE4 homogeneous allele, you're at much higher risk of getting Alzheimer's disease, for example, but you can still try and control all these risk factors so that you might get your Alzheimer's disease at a later age. And 45% is huge. So we really do want to try and prevent as much dementia as possible. And this is from the 2024 Lancet review. Every few years they come up with with a new one, and there are a few more risk factors that we can modify. And just to reiterate, 45% is huge. So when we're looking at treatment principles of dementia, there are cognitive enhancers, things like your acetylcholinesterase inhibitors and your NMDA receptor antagonists. The acetylcholinesterase inhibitors work better for mild to moderate dementia. The NMDA receptor antagonists you use more for your moderately severe to severe dementia. If they stop working or if the side effects are worse than the actual disease, then you stop them. There are DMARDs, which are targeted anti-amyloid therapies, not available in our country at the moment, hugely expensive. They're every 2-week infusions, and the clinical trials are a bit iffy. So they do remove the amyloid, but does it relate into actual clinical improvement? We have to wait and see. Then obviously, if there are any risk factors, we have to treat those because, as you can see, they contribute up to 45% of dementia. And then we have to treat the behavioral and psychological symptoms of dementia, which we're going to talk about in a second. So just to remember that medicine doesn't work for all dementias. Your cognitive enhancers are better for your Alzheimer's dementia. There's no cure for dementia with Lewy bodies or Parkinson's disease dementia, or frontotemporal dementia. You can just try and control some of the symptoms. And the most important is a supportive environment with adequate levels of care. So you might need help with your activities of daily living. Is driving safe? You have to assess that. The patient probably needs a nice, safe routine where Monday to Sunday is all the same. Like a nice, comforting routine is very helpful to the brain. You also have to look at what medicines to discontinue, those that aren't helping, and where can the caregivers get some support. So there's some very good organizations in South Africa, Alzheimer's Dementia and Dementia South Africa, and their websites have so much information on support for the patient and for the caregivers, because caregiver burnout is real. And they've got lovely, just simple things to explain what happens, why it happens, how to try and mitigate some of the behavioral issues with dementia. And sometimes they have support groups. And it's nice to know that when your family member and loved one is suffering from dementia, it can feel very isolating, but you're not alone. And there are lots of people in the same boat. And sometimes they have some nice tips and tricks that you haven't thought of that might really help you and your family member. So now we're just going to spend a few minutes on the aggressive demented patient. I don't know if you remember in Australia, this 95-year-old granny came at her caregivers with her walker, her Zimmer frame, and her butter knife, and they called the police, and the police tasered her because, I mean, they must have thought that she was a real severe threat. So if we look at the behavioral problems of dementia, this is a lady who was living alone. She had dementia. They couldn't really care for her. They moved her into an old age home, and then they moved her into memory care eventually. And then she walked out of the gate and got lost in the city. And this is just part of dementia. The wandering is a real thing. You just have to, institute some safety precautions like locking the gate. Then this man who's got vascular dementia becomes very, very shouty and aggressive in the afternoons. And this is typical of sundowning, which is one of the problems with dementia. And we'll talk about it now. Then this 72-year-old lady has man has Alzheimer's dementia, moderately severe, and he lives with his caregiver, and he fights with her about eating and bathing, and he's hit her on a number of occasions. So this is the behavioral and psychological symptoms of dementia, and this is very dangerous because if you knock out your sole caregiver, no one's going to look after you, and that's really worrying because you're not going to be able to look after yourself. So with this patient, we might have to give more aggressive treatment. And then just to remember that dementia is not delirium, and you have to always rule out a delirium and, treat a delirium. But you can't, it's difficult to diagnose dementia in the face of delirium. So you first want to treat the delirium, let it settle, and then decide whether the patient has dementia or not. So if somebody's got pneumonia and they're running around, jumping over their cot beds, restraining them is not actually the answer, but treating their delirium is, and that's a talk on its own. So if we look at the behavioral and psychological symptoms of dementia, they're common, up to 60% in the late stages. And it can be cognitive problems like seeing things, motor issues like wandering, verbal like repetitive noises and sounds and words. It can be emotional, like emotional ability, just crying at the drop of a hat or laughing inappropriately. And then vegetative, which are your apathetic patients. And this has an impact on prognosis and management. So your behaviors are things that you observe, like the person's aggressive, screaming, restless. And this actually causes more caregiver stress, and the patient then lands up in an institution. Whereas your psychological problems are things like anxiety, depression, hallucinations, delusion. And these you get more with interviewing the patient and the caregiver, and this leads to a lot of patient suffering. Then when you're looking at sundowning, which as we said are the worsening symptoms when in the late afternoon, early evening, it's when the light fades and there are more shadows and the person just has trouble distinguishing between what's real and what isn't. Often there's a lot of noise and it's worse if they're in an unfamiliar surrounding. The treatment isn't to give a medicine, it's to stick to a daily schedule, make sure that the person is sleeping at night and not having too many daytime naps, get enough sun every day, get enough physical activity, and try and limit alcohol and caffeine later in the day. I mean, you shouldn't really be drinking alcohol earlier in the day either. So maybe just like a cup of coffee or a cup of tea in the morning, but by midday, cut that out. They're very, very common. Things like your aggression and your agitation and anxiety are much more common than other, symptoms such as hypersexuality and obsessive compulsive disorder, but often the mood symptoms precede the dementia diagnosis by a number of months. So the person knows that something's wrong. They just can't put their finger on it, and they become quite depressed and a bit more withdrawn. And then the behavior problems like the agitation, aggression, wandering usually happen after the diagnosis of dementia has been made. So there's just this, the before and the after. So more mood before, more behavior after. You can do a whole lot of tests. In geriatrics, we love putting a scale to everything. So there's something called the neuropsychiatric inventory, but basically you take a whole lot of symptoms like your delusions, hallucinations, depression, anxiety, and you say, are they present, yes or no? And are they mild, moderate, or severe? And obviously, if they're mild and they're not worrying the patient too much, you're going to leave it. But if they're very severe and they're causing undue distress, you are going to do something about it. You can also assess the agitation, and you can, here you basically decide whether the person's physically aggressive, physically non-aggressive. So this is just things like wondering. If they're verbally non-aggressive, like just saying, phrases over and over again, or if they're verbally aggressive and screaming and shouting at you. Obviously, if you're physically aggressive, it's much more worrying than somebody who's just pacing up and down. And if you're physically aggressive to the people who are caring for you, you need to treat that aggression. Whereas if you're wondering, you might just have to, lock the garden gate and lead the person back to their room. When people do have behavioral problems and they've got dementia, they could have some underlying distress. So there's something that's worrying them, or they've got some unmet need. So they've got pain that they can't verbalize, or they're trying to tell you something, or they need something, like they need to go to the bathroom, or they need to eat something, and you just can't really understand what they are trying to say. There are some factors that we can modify when it comes to these behavioral problems. So often the families are very distressed, so educating them about the condition really does help. You can give the person a nice routine. You can try and sort out their unmet needs or their pain, or if they've got any acute medical problems. There's some things that you can't modify. So you can't modify the patient's pre-morbid personality. You can't modify what happened to them in their life. You can't really often modify family dynamics. You can't modify the actual disease process. So there's certain things that you just have to work around because they're there, and there's some things that you can try and fix. Some are patient factors and some are environmental factors. But just to note that the things that you can fix, you should fix. Behavioral problems of dementia are also not delirium. Remember, people with delirium are at a much higher risk people with BPSD are at a higher risk of developing delirium, but you have to rule out the triggers for delirium, which can be similar. So again, things like drugs, not being able to see or hear, low oxygen state, infection, or if they're mobile, if they're restrained, if they've got urinary retention, if they've had a seizure, any intracranial problems, if they underhydrated or poorly nourished, or metabolic abnormalities, or if there's any sleep deprivation, or if they're sore and pain, just to sort those out first and make sure that they're not having a delirium. This is just a good time to remind you that a delirium in an older person is not only a UTI. There's this whole host of causes. You can't actually medicate all your behavioral symptoms of dementia. So things like apathy, screaming, hoarding, wondering, verbalizing, you can't isolate. You also can't really isolate. You can't medicate uncooperativeness. So you can just try and manage it as best you can, but there's no medicine that's going to cure this problem. So non-pharmacology is obviously the first line. You need a good relationship with your caregiver. So they need to know what you want in a nice, calm, supportive environment. Just take safety things into account, like locking doors and that sort of thing. Obviously, if the patient loves doing something, like they like to knit, they can continue knitting, but don't expect them to learn new activities. And then tolerate, anticipate, and don't agitate. So it's a DAR approach. So if they tell you that today's Tuesday, you tell them actually today's Thursday. And then if they insist today's Tuesday, you just go with it, because otherwise you'll just frustrate yourself. And also there's this ABC approach where you look at what sparked the behavior. So for example, if you try to bath your loved one and then they get very, very agitated and then they hit you, maybe they don't need a bath. Maybe, being washed in the chair is actually good enough. Sometimes you just have to make do with what you can. Then it also depends on the stage. So you do activities that the person enjoys, like art therapy, music therapy, keep on orientating them, spend time with people that they like. And then, of course, care is the most important. So either at home or in a facility, depending on finances, resources, patient preferences. But a person who's got, moderate dementia cannot live by themselves. And then you only medicate patients when they're a harm to themselves or others, or if they're in extreme distress. And how you're going to medicate them, you're going to start low, stop if there's no benefit, and your benefits must outweigh the risk. And you're going to look at drug interactions and side effects. There's a whole host of treatments you can use, but if you treat 5 to 11 patients, you're only going to result in having 1 reduction in your behavioral problems with a much higher risk of mortality. And we usually use antipsychotics, antidepressants, sometimes melatonin and your NMDA receptor antagonists or cholinesterase inhibitors, and sometimes painkillers. We really don't advocate for any of the other treatments like your benzos, anticonvulsants, cannabinoids. And you only, again, if they're extremely distressed and a harm to themselves, and you use the lowest dose possible for the shortest amount of time, usually 4 to 12 weeks. And the risks are death, stroke, falls, pneumonia, arrhythmias, extrapyramidal side effects, Parkinsonism. So sometimes the risks far outweigh the benefits. And here you can see the doses that we use. So we use quetiapine at really, really small doses, 12.5, maximum usually 75. You can use olanzapine, 2.5. Risperidone starts at 0.25, haloperidol at 0.5. So we're not using the massive doses that we give to our psychotic patients. But just to remember that all of these antipsychotics have a black box warning. So you really do have to choose the patient carefully and think before you just prescribe. Obviously, if they're not working, please stop before you just add more and more. And then just a few take-home messages. Screening for your major neurocognitive disorders is quite easy, and it's important for follow-up and to put preventative measures in place. Always rule out your mimics and reversible causes, because those you can do something about. And also, if you know what your mimics and reversible causes are, you already know how to work your patient up for dementia. Because if you know that things like normal pressure, hydrocephalus, etc., are a cause of reversible dementia, you're going to do an MRI or a CT scan. If you know that a vitamin B12 deficiency is a cause, you already know that you're going to do a vitamin B12 deficiency in your workup for the patient. So knowing that mnemonic is quite useful for workup as well. And then just for your behavioral and psychological symptoms of dementia, non-pharmacological therapy is the first line, and you only use pharmacological therapy, if the patient is extremely distressed or a harm to themselves or others. And that's me. I'm just going to stop sharing for a sec. There we go.
Thank you so much. Thank you so much. This was quite a very lovely presentation. I haven't heard for it for a while. It's great. I just want to ask you one question. I have a gentleman who's happened to be a colleague. He's about in his 50s, who actually having amyloid related dementia. Obviously, you have to leave his work and got the memory issues. And I'm very excited when you say that there's actually new treatment, the anti-amyloid treatment. Can we access it? Because it's got somebody who could afford it and any experience with it?
No experience with it. It's not available here. It's available overseas. It's hugely expensive. I think it was $75,000. It's a lot of money. And it's a 2-weekly infusion, and it does get rid of the amyloid. But the trials were done when the patients had very, very mild disease. So, it hasn't related very much to clinical improvement, which is a problem. So you might be getting rid of the amyloid, but what we want in clinical practice is, for the patient's memory to improve, for their function to improve. And that just, at the moment, it hasn't been shown. You know, their trials are always ongoing.
Yeah. There are quite a lot of people online. So I'm not sure if anybody online have any questions for Dr. Greenstein.
Any question, guys?
I'll preempt a question. So I was actually expecting somebody to ask about biomarkers. You know, you can sort of do biomarkers for Alzheimer's disease and, you know, would you do it? Wouldn't you do it? And that's a whole ethical, you know, discussion on its own. If you've got a disease that there's no treatment for, like, do you actually want to know? So maybe in a case where the person's got a dementia and you can't really decide what it is, then it's a good idea to do it. But I mean, I don't know if I would do a biomarker now, because then I'm just going to, every time I forget something, I'm going to start panicking. Is it dementia? Is it just, you know, normal day-to-day stresses? You know, what's going on?
Yeah.
Suzanne, got a question.
One with that.
Good morning, everyone. I just want to again, can you just briefly go through which is the medication we must not give the Lewy body patients? Because I remember, but I just want to catch up again, please.
Oh, sure. Sorry, I skimmed through that. So they have, they get very stiff if you give them any of your antipsychotics, and then they're at much higher risk of aspirating. So you don't want to give them any antipsychotics, or you want to be very wary when you give them antipsychotics. If you have to choose one, quetiapine at a very low dose, if they're very distressed and very and they're harming themselves, is probably the better option. But try and avoid any of your antipsychotics. And then we don't really like benzos much because of all the risk of falling and all the cognitive side effects. And we don't like anticholinergics because of all the side effects. But obviously, all drugs do have their place. So if your patient's got a delirium, for example, from alcohol withdrawal, please give benzos. Or if they're withdrawing from benzos, please give benzos, but just not for long-term treatment of dementia.
Thank you.
Any other questions? And then, you know, dementia has always been quite very challenging. In terms of the, when do you actually consider demented patient as a population, actually? Yeah, I mean, we see them quite a lot. And the question that, does dementia means end stage? Can we equate dementia to like stage of cancer 4? I mean, can we do that? When do we withdraw?
So you know what, it's quite useful to screen patients who are over the age of 65 just with a mini cog in your normal day-to-day practice, if they complain about any, you know, memory issue, or if you've got a suspicion. And often there's like quite a long prodrome where they've just got a bit of memory issue, they repeat themselves a bit, they forget a few things, but they're actually okay. And if they use a diary, you know, to remember things, that's fine. It's just good to track the progression and just to try and modify all the risk factors that you can to, you know, sometimes at that point, giving them a memory enhancer, if you think it's more Alzheimer's, is really useful, you know, just to try and slow down the progression. But it doesn't mean that it's end stage and that nothing can be done. You know, people can still live for quite a long time relatively independently, but they do need to start putting measures into place in case things deteriorate.
Thank you. Suzanne?
Sorry, me again. I just want to know, because I'm a palliative doctor, so I'm doing now most of my patients are the end stage dementia patients, and I must say they have a way of keep on living more than 12 months. So I always say with the dementia patients, you can't say it looks like end stage, and then by putting things in place, they can go on for quite long. But when do you start stopping things like the statins, the cholesterol medication, because now most of these patients, they have so much medication to drink. So how long do you carry on giving them statins? How long do you carry on giving them Memor and Donacep and stuff? Because where do you draw the line of saying, you know what, now this is not really going to benefit anymore?
Okay, so your Memor and your donepezil, those are your memory enhancers, your cholinesterase inhibitors, and your NMDA receptor antagonists, don't work once the person has severe dementia. So when the mini-mental is less than 10, you're definitely not going to give those, and you're going to stop, because they just cause more side effects compared to the benefit. Statins usually within the last year of life, but as you've said, it's really difficult to decide when that last year is. So, there you have to use clinical judgment and, discuss with the family and the patient, because you also don't want to have a stroke that's going to just cause more disability but not death, or a cardiovascular event that's going to cause disability, that's going to make quality of life worse. So it's difficult, but usually within the last year or 18 months of life. And then obviously you do a medication review and you stop everything that's not actually necessary. So if they're on like iron supplements and they don't have an iron deficiency, for example, please stop it. Or if they're on like a trillion or supplements, like one multivitamin will probably do the trick. You don't, and all of these memory enhancing supplements as well, they don't, when there's end stage, it's nothing's going to work. You just want to stop things that are going to cause harm.
And Lara, just quickly about, because we know that admit quite a lot of demented patients in the ward, and one of the things, of course, we live in a country that's well polarized, and sometimes some of these patients, they will have the dementia with a bit of some psychotic features. Sometimes they're very aggressive toward the nurses, and sometimes they become like a race issue, and they become problem caring for the patient in general. The question that what would be the best way that we could actually educate the nurses that this person is not something personal, and it's not that this, it's not what we're seeing. It's just we have to continue giving them care, because sometimes they come with infection, and obviously, if they have UTI, which is more urosepsis, one of the commonest things that they present with, or pneumonia, and sometimes then they become very aggressive, and could be temporal problems. How do we actually get to our nurses to understand from day one that, listen, this is not what you see outside the walls of the hospital. This is just a sick person who, unfortunately, that based on our history, could say whatever. Sometimes they say they have really no control over that.
Also, it's difficult for the nurses and the staff. It's also difficult for the family. You have to keep on reminding people that this isn't the person. This is the disease. So the disease is doing this. It's not the person's personality. It's not them saying it to you. It's just very unfortunate that, the disease does this, and you just have to try and look past it. It is very difficult. What does often help is if the person has a caregiver that they really trust and like, if they can sit with the person even while they're in hospital, it makes a huge, huge difference, because, and then that caregiver can also remind everyone else, this is the disease, not the person. And, obviously, if they're very, very aggressive and they're causing harm to other patients and themselves, you are going to need low-dose antipsychotics at that point. But again, low dose, just make sure that the patient's safe, that you're not going to, that you don't give massive doses like you would for a 20-year-old who's got this, who's got psychosis, for example. And also just orientating the patient again to time, place, person sometimes does help. Pictures of their family, because often being in a horrible environment, hospital is not a nice environment for anyone who's unwell. It can be quite distressing to them.
Lara, I just want to ask one question that comes up also quite regularly for us. What are your thoughts on peg tubes? It also relates to palliation. In patients with dementia, as you said, they forget how to swallow, they can no longer swallow, they start aspirating. They're no longer mobile necessarily, they're in bed. What's your opinion on, is it a personal decision for the family to decide whether to continue and insert PEG tubes, or what do you think about that?
Okay, so first prize would be when the patient's diagnosed with dementia early in the stages, to have an advance directive to decide what they do or don't want, so that you're not, sticking tubes in people that don't actually want it towards the end. And I'm sure most people don't want to prolong life, when there's no meaningful chance of recovery. But again, personal, religious, spiritual issues. Then there's a campaign called the Choosing Wisely campaign, which actually advocates against PEG feeding in advanced dementia. However, obviously, if the family is insisting on it and there's no advance directive, there's not much then that you can do. But it doesn't solve any of the problems. You can still aspirate with a PEG tube.
Yes.
So careful feeding. Sorry?
I think it comes down to the education of people. Yeah. I think we often find that the family, they don't always realize that this is the cause of the disease, and it's a surprise to them, and it comes down to probably educating them much, much sooner.
Yeah, so there's a lot to do with education, and also to choose these difficult conversations and have them relatively early. But also the speech therapists are great. They've got tips and tricks. So, sitting the person up, giving them softer food, fizzy water instead of still water just helps you able to swallow, sometimes positioning the head, that sort of thing. There are tricks to it.
Yeah, thank you.
Suzanne?
I just want to add something there. I did a lot of reading on the PEG tubes in dementia and so on. So if you want, the Irish Hospice have a very nice guideline. So quite a few books, but then one of them goes about artificial nutrition and hydration in dementia patients. And then it's written for families, so it's not like just medical high terms. And I find it very useful to give to families to read it. It gives them a bit of insight on how does it work in a patient with dementia. Why rather give half a teaspoon, let them swallow, and so it just explains everything to them, and it helps them to make the decision: are we going to go PEG wise or not? The sad thing is, I think a lot of our colleagues are just, no, the patient don't eat, don't swallow, needs a PEG. And that's a sad thing, because a lot of patients go into hospital with a pneumonia, comes out of a PEG, where it was really not necessary if there was good education. So yeah. I sometimes feel we need to start with our fellow colleagues and learn them about what's the place for a PEG.
That's exactly what I'm asking. Thank you so much.
So that's a very, very nice thing to go and look at Irish Hospice's guidelines on dementia. And I think it's book 4 that goes on artificial nutrition and hydration. And they have very nice tips also and stuff.
Thank you so much.
I really believe that we need a geriatrician in every hospital. The fact that in pulmonologists every hospital, I think that will probably improve our care of patients, because currently in South Africa, it's not a third world country, but we have a mix of first and third world country. And I think we've seen quite a lot of elderly population. I mean, midstream, as we said, Leanne told you, the average age is between 80 to 82, if not 75. And most of these patients have some underlying kind of decline in cognition. And I think it probably would help that if we would probably, have more presentation like this, because yesterday I might not have a lot of insight like what you have presented. And I think for me, it's quite an eye opener, and perhaps maybe would be nice one day you can just give us more presentation.
I'd love to, anytime.
Oh, great. We're going to ask you every week.
Thank you so much. I think we have to wrap it up, because I know Dr. Greenstein has a lot of other commitments. So thank you so much for your time, and good luck everybody with your day and the rest of the week.
And we always love your presentation.
Thank you so much for having me. Have a good day. Bye.
Bye.
Thank you for your time.
Thanks.
Thank you.
Bye.
Thanks, Suzanne, for the contribution. This was nice.